Hi class, this recorded lecture is going to be about the cardiovascular system. While you have all taken anatomy and physiology, I would still take a look at the anatomy of the heart, just as a quick review. Here's a little review on the blood flow through the heart. The right atrium, over here, is going to receive venous blood from the inferior and the superior vena cava and the coronary sinus. The blood then passes down through the tricuspid valve into the right ventricle here. With each contraction, the right ventricle pumps blood through the pulmonic valve. So you will see that blood go up this way to the left pulmonary artery into the lung, as well as into the right pulmonary artery into the right lung. Blood will then flow from the lungs into the left atrium through the pulmonary veins. So at this point, you have oxygenated blood. So you have left pulmonary veins and your right pulmonary veins. So this is where, again, your oxygenated blood will re-enter in through the heart, into the left atrium, through the mitral valve, and then it will go from the left ventricle up back out of the aorta. So this is where the blood is then going to be brought back to the rest of the body with that oxygenated blood. This is good for you to look at in terms of the blood flow through the heart, and this will be particularly important when you get to coronary artery disease. So as a quick review, the myocardium pretty much has its own blood supply, and this is the coronary circulation. The blood flow into the two major coronary arteries will occur primarily during diastole, so again, the relaxation of the myocardium. The left coronary artery will come from the aorta and divides into two main branches: the left anterior descending artery and the left circumflex artery. These arteries will supply the left atrium, the left ventricle, the left interventricular septum, and a portion of the right ventricle. The right coronary artery will also come from the aorta, and its branches will supply the right atrium, the right ventricle, and a portion of the posterior wall of the left ventricle. In about 90% of people, the atrioventricular, or AV node, and the bundle of His are part of the cardiac conduction system, so they'll receive blood supply from the right coronary artery. And because of this, obstruction of this artery will often cause really serious defects in cardiac conduction. The coronary veins are parallel to those of the coronary arteries. Most of the blood from the coronary system will drain into the coronary sinus, which is basically a large channel, which empties into the right atrium near the entrance of the inferior vena cava. Now let's talk about the cardiac valves. The four valves of the heart really serve to help keep the blood flowing in a forward direction, so it prevents regurgitation, or in other words, that blood going back into the area that it just came from. The cusps of the mitral and tricuspid valves are attached to these really thin strands of fibrous tissue, as you can see on these images here. So here we have the tricuspid, and here we have the mitral, and this is supposed to be that thin fibrous tissue. And these will kind of anchor these valves into the papillary muscle of the ventricles. Now the support system will help to prevent eversion of those little leaflets into the atria during ventricular contraction. So in other words, if you look at this image on the right, as the blood goes through the right atrium into the right ventricle, these little leaflets will close and prevent backflow from the right ventricle back into the right atrium. Depolarization is going to trigger mechanical activity. So let's talk about some of those mechanical properties of the heart. First is systole, which is, as you know, contraction of the myocardium, and this will lead to ejection of the blood from the ventricles. And relaxation of the heart is diastole, which allows for the ventricles to fill with blood. Stroke volume is the amount of blood that's ejected from the ventricle with each heartbeat. And cardiac output is the amount of blood that's pumped by each ventricle in 1 minute. That's determined by multiplying the heart rate by the stroke volume. And lastly, mean arterial pressure is the average of systole and diastole. And this is clinically significant because it measures the pressure that's really needed for adequate perfusion to the organs. And it's also thought to be a more accurate evaluation of how well the body is perfusing. With mean arterial pressure, it can be influenced by several different factors, including cardiac output as well as the systemic vascular resistance. Numerous factors can affect either the heart rate or the stroke volume, and therefore the cardiac output. The heart rate, which is mostly controlled by the autonomic nervous system, can reach as high as 180 beats per minute, but for short periods of time, it's not going to cause any harmful effects in someone who has a healthy heart. The factors affecting the stroke volume are preload, contractility, and afterload. Increasing preload, contractility, and afterload will increase the workload of the heart muscles, which then leads to an increased oxygen demand. Now you may wonder, what is preload, afterload, and contractility? Well, with preload, this is the volume of blood in the ventricles at the end of diastole before the next contraction. Preload helps to determine the amount of stretch that's placed on the myocardial fibers, and it can be increased due to a number of conditions such as aortic disease or even hypervolemia. Contractility refers to how well the heart is contracting or squeezing, and it can be increased by epinephrine and norepinephrine, which are released by the sympathetic nervous system, which you may remember is also fight or flight. With increased contractility, that's going to raise or increase the stroke volume by increasing ventricular emptying. And lastly, afterload is the amount of pressure that the heart needs to exert or to use in order to eject the blood during the ventricular contraction. Afterload can be affected by a variety of things, such as the size of the ventricle, any tension on the heart walls, as well as the blood pressure. If the blood pressure is elevated, the ventricles will meet increased resistance to ejection of the blood, which then increases the workload on the heart. Over time, this can lead to ventricular remodeling, and in particular, ventricular hypertrophy, which we'll get into a little bit later. It's important to remember what the arteries and the veins do. The arteries will carry oxygenated blood away from the heart back to the rest of the body, whereas the veins will carry deoxygenated blood toward the heart so it can be oxygenated. It's very important to remember that the pulmonary arteries and veins are exceptions to those rules. So the pulmonary artery will carry deoxygenated blood to the lungs, and the pulmonary veins will carry the oxygenated blood back to the heart. With blood pressure regulation, there are a variety of factors that can affect it. First and foremost, we have the autonomic nervous system, and this is going to, as you know, consist of the sympathetic and parasympathetic nervous systems. Stimulation of the SNS will increase the heart rate, which then will lead to an increase in the speed of impulses that are conducted through the AV node. And then this will lead to more force of atrial and ventricular contractions. As this occurs, there is going to be stimulation of certain receptors in the smooth muscle of the heart, and it will lead to vasoconstriction, which will then increase the blood pressure. In contrast, stimulation of the parasympathetic system, which is going to be mediated by the vagus nerve, will slow the heart rate by decreasing the impulses from the SA node and therefore the conduction through the AV node. The kidneys also have a strong influence on the cardiac function. The kidneys can sense a change in blood flow, and then it will activate the renin-angiotensin-aldosterone mechanism, or the RAS system. The endocrine system can release various hormones such as catecholamines, serotonin, histamines, and these can stimulate the sympathetic nervous system at the tissue level. And lastly, baroreceptors, which are in the aortic arch and carotid sinus, these are sensitive to stretch or pressure within the arterial system. If these receptors are stimulated, which could be from a variety of things such as fluid volume overload, this will send information to the vasomotor center in the brainstem. This then results in a temporary inhibition of the sympathetic nervous system and then enhancement of the parasympathetic influence, which will cause a decrease in heart rate and peripheral vasodilation. Decreased arterial pressure will cause the opposite effect. As we age, our heart doesn't quite function as effectively as it does when we're younger. And this is partially because the pacemaker cells will decrease and ultimately conduction time will take longer. With the conduction system, if the size of the left ventricle is increased and there are fibrotic changes in the left ventricle, this can decrease the speed of early diastolic filling. Over time, the aorta and other large arteries can thicken, which then causes the systolic blood pressure to increase, which is a compensatory mechanism. The systemic vascular resistance will increase because of the stiffening of those arteries, and then it leaves the left ventricle to basically pump against a greater resistance, which then can lead to ventricular hypertrophy. Lastly, there are those baroreceptors again, and over time, as we age, they just become a little bit less sensitive, meaning they're going to work a little bit less effectively. With your patients who have a cardiac history or any symptoms of cardiac distress, it's super important to take a really good health history and have a good physical exam, because this helps you to determine if the symptoms are directly related to the cardiac system or if there's maybe a secondary cause that's leading to the symptoms. There are a ton of things that can affect the cardiovascular system either directly or indirectly. You can get a lot of information from patients if you ask the right questions. So asking about things like any history of chest pain, do you have any shortness of breath? If you do, is it with rest or with exertion? Any tiredness? Do you smoke? Do you drink alcohol? If you do, how much for both of those? Any history of rheumatic fever as a child? Any recent infections? Have you ever been told that you have a history of any heart problems, any blood pressure problems? Do you ever feel like your heart's skipping a beat, etc.? So there's a ton of questions that you can ask, and that really helps to guide some of your physical assessment as well. I'm sure many of you have noticed in the clinical setting that sometimes your patients are not the best historians. So if you ask about medications, this can also clue you into potential issues that the patient has. For example, if your patient says they don't have any cardiac history, but they tell you that they've been taking lisinopril for the past few years, then that tells you that they probably have a history of high blood pressure. You also need to ask about over-the-counter medications, which includes herbal supplements. There are some herbal supplements that can thin the blood, so this is important to know when you're doing your intake assessment on a patient. Also, do they take any other over-the-counter drugs? Cold medications, for example. Some of your cold medications have either aspirin or acetaminophen in it. Aspirin can be particularly important to know if we're talking about cardiac health, because we know that aspirin can thin the blood. Doing a functional health history can help to give us a lot of information. This can help us to identify areas in which a patient maybe has issues with ADLs or fulfilling their normal roles, as well as maintaining their health and well-being and what health and well-being means to them. Health perception can be something as simple as, do you feel like you're healthy? And with health management, what do you do to take care of yourself? Nutritional and metabolic patterns can include simple questions like, what do you usually eat on a daily basis with your diet? Elimination patterns, how often do you have a bowel movement? Can you describe it to me? As well as urinary habits, but you can also ask other questions like, do you ever notice any swelling of your feet or ankles? If they do, how far up the legs does it go? Or you can ask questions like, do you ever take medications like a water pill to help you get rid of swelling? Activity and exercise pattern is pretty self-explanatory. Do you exercise? If you do, how often? What kind of activities are you participating in? But you also want to ask questions like, do you feel like you can fully participate in those activities? Do you find that you have to take more frequent rest periods? Sleep rest pattern can also tell us a ton of things, especially when it comes to cardiac. You can ask, where do you usually sleep at night? Do you sleep in your bed? If so, how many pillows do you sleep with? Has this changed recently? This is particularly important when we get to talking about left-sided heart failure, because you may have some patients who will tell you, I can't even sleep in my bed anymore. I usually just sleep in the recliner because I'm more comfortable. Otherwise, I get short of breath and feel like I can't breathe. Another important question could be, do you ever get up in the middle of the night to urinate? If so, has this changed? Do you feel like you're getting up in the middle of the night more frequently to urinate? And of course, this could be something beyond something like a cardiac issue, but still an important question to ask. I encourage you to go through the rest of these bullet points and think about what kind of questions you would ask for each of them. Physical assessment, as you know, is also a very important component of a health history and assessment. First, how does the patient appear? Do they appear comfortable, uncomfortable? Do they appear well-appearing, ill-appearing? So their general appearance can tell you a lot of things right off the bat. What is their skin color like? Is it consistent with ethnicity? Is it even in tone? Are they cool and clammy with their skin, or are they hot to the touch? What about the extremities? Do they have any swelling, any dependent rubor, which we'll talk about a little bit later, any clubbing of the nail beds, any varicose veins, any ulcers or wounds that you would need to address? The need to assess blood pressure should be pretty self-explanatory. Our peripheral pulses, so when you are assessing the radial and pedal pulses, for example, are they a 0, 1, 2, 3, 4 plus? Are they equal? So when you are evaluating these, as you know, you need to evaluate them at the same time to make sure that they are equal in strength. With the chest, we are, of course, first inspecting, again, even skin tone. Is there equal chest expansion? Is the breathing even and unlabored, or is it labored? If it's labored, do we have deep breaths or shallow breaths? And then, of course, palpation. You're assessing the skin. Is there any abnormality that you're feeling? Percussion, as you know, we don't really do this as an RN. You just at least have to know that concept. But more importantly, auscultation. At this stage, you should be able to identify, do the heart sounds sound normal, which normal would be regular rate and rhythm. If you have a patient who's tachycardic, you can still determine if the heart rate is rhythmic. Does it sound like it's beating at the same time? If you have an abnormal heart sound, this could be a variety of things. This could be from a dysrhythmia, something like atrial fibrillation, or maybe someone is having palpitations and it sounds like their heart is skipping a beat. You guys will learn a little bit more about that when you get to a later med-surg course, but at this stage, as long as you're able to identify, do the heart sounds sound normal? Here we have some tools to determine, for example, your peripheral pulses. You should be grading them. Is it a 0, 1, 2, 3, or 4? 0 would obviously be a bad thing because it means that you don't feel one. However, when in doubt, if you don't feel a peripheral pulse, you can always grab a Doppler and see if there is indeed a pulse there. So look at the whole picture. Don't freak out right off the bat. You can also ask your nurse as well as your clinical instructor to see if they can help you to evaluate it. There are some patients who are just really difficult to palpate their pulses. A grade 1 is considered to be a weak pulse, so this is thready. And what does thready mean? Well, that's a smaller, more fine pulse, and it feels more like a small cord or even a thread under the finger. So in other words, it's a lot more difficult to palpate, but it's still there. A grade 2 is considered to be normal, so this is easily palpable. A grade 3 is not necessarily abnormal, so this would be kind of like a high normal, and this is easily palpable, but stronger than just the normal pulse of a grade 2. And lastly, we have a 4+, which is a bounding pulse. This means it's really strong, very easy to find. It could be indicative that there is an underlying cardiac disease. So if your patient is just laying there, hanging out, and they have a 4+, that could be a bad sign. But if your patient has just run a marathon or they have had some sort of vigorous exercise, then having a 4+ would not necessarily be a concerning finding. I know at this stage everyone knows how to find the apical pulse. Well, now as you're getting into more of a deep dive into how to assess the cardiac system, you should know the 5 cardiac landmarks. If you look at this image here, this shows you where those landmarks are. You have aortic, pulmonic, herbs, tricuspid, and mitral. The mitral area is the same thing as your apical pulse or PMI, which is your point of maximum impulse. All of those are one and the same. So when you are listening to those 5 cardiac landmarks, If you have a patient with a cardiac history, you should also know to listen with the bell. The bell will help you to pick up more lower pitched sounds more effectively. For example, if someone has a murmur, listening with the bell, the smaller side, will help you to pick up those sounds better. This image that I have here on the slide is one of many mnemonics out there to help you remember where those cardiac landmarks are. So this particular one is all pigs eat too much. So all pigs eat too much. Labs can also tell us a ton about how a patient is doing overall. Sometimes people will have these underlying symptoms but have no idea that they have any cardiac issues. But then we look at labs and it tells us a lot of information. Cardiac enzyme tests such as your troponin will usually be done for a patient who is having something like chest pain. And troponin is a type of protein that's usually found in the muscles of the heart. Troponin isn't normally found in the blood, so when the heart muscles are damaged, such as with a myocardial infarction, the troponin is released into the bloodstream. So a higher troponin is a bad thing. I'm sure all of you have at some point in time either had your lipid panels done or you know someone who has. And there are different things that we look at with the lipid panel. We of course have cholesterol, and this really helps us to determine risk factors. In general, you want your total cholesterol to be less than 200. If it's higher than that, then that could put us at higher risk for things like coronary artery disease if we don't make any lifestyle modifications. With cholesterol, there's a lot of debate on what's good versus bad for lowering cholesterol. If you look at your PowerPoint, you'll see that there's a link for a YouTube video. It's more of a humorous video, but it does really make a lot of sense in that there's a lot of debate on eggs, for example. Can we eat eggs? If we eat eggs, is it going to make our cholesterol levels go up? And over time, you've heard some debate that you can eat eggs, but you can only have the egg whites. And then you'll hear other individuals say eggs are totally fine. So a general rule of thumb that I tell patients is everything in moderation. Triglycerides are a type of fat, and these are the most common type of fat in your body. We usually want our triglycerides to be somewhere below 150, so the lower the better with this one. High-density lipoproteins, or HDLs, are your good type of lipid. So we actually want this type of lipid to be higher. If you notice on this little chart here, you have between 40 to 60. So if we have above 60, that's a good thing. LDL is your low-density lipoprotein, and this is mostly cholesterol. So we want this to also be lower. In general, we want this to be somewhere between 70 to 130. Depending on the lab, you may see below 120 or even 100. Just know the general range because this will change depending on the lab. Overall, elevations in triglycerides and LDLs are strongly associated with coronary artery disease. So we want people to have lower levels of this. And again, your HDLs are your good type of lipid. This helps to serve a more protective role by mobilizing cholesterol from the tissues. When we look at our lipids, cholesterol alone is not going to be indicative of something like coronary artery disease, but we just know that we have to keep an eye on it, and we also need to look at the other lipid levels. If someone has high cholesterol, high LDL, and high triglycerides, then that would be much higher risk of developing cardiac issues like coronary artery disease. Homocysteine is an amino acid that's produced when proteins are broken down. Now, a certain amount of homocysteine is present in the blood, but if it's elevated, it could be an independent risk factor for the development of cardiovascular disease. Some of you may recognize this other lab, C-reactive protein, or CRP, from our discussion on arthritis, particularly with rheumatoid arthritis. Now, this is a protein that's made by your liver, but this is more of a general inflammatory marker. So if we see that the CRP is elevated, it doesn't necessarily mean cardiovascular disease. It just means that there's an inflammation occurring. Lastly, we have fluid and electrolytes. If we have someone who has heart failure, for example, we may see an alteration in sodium and potassium, especially if there's renal involvement. So this is just a general lab that is commonly evaluated to see if there are any other factors contributing to cardiac conditions. As the RN, you may anticipate that the provider may order some other types of diagnostics, especially if someone's having cardiac-related symptoms. A really common one is going to be your ECG or EKG. This is done at the bedside. This can tell us a lot of different things about cardiac function. Do we have a regular rate and rhythm? If we don't have a regular rate and rhythm, what kind of rhythm do we have? So does this patient have something like AFib? Are they having a myocardial infarction? So again, this can be very telling on what's going on with the patient. A chest x-ray is another common one, and this helps us to determine if someone's having, for example, shortness of breath. Well, is it more cardiac related or is it respiratory related? If they have a history of cardiac issues, it can also tell us what the size of their heart is. So it can provide a baseline, but it can also help to determine if they have any cardiomegaly or enlarged heart. Cardiac catheterization can also be done, and this helps to diagnose or even treat certain conditions, such as clogged arteries or even irregular heartbeats. This helps to, again, further evaluate. So they'll inject a dye. If you look at this image here on the left, these are the coronary arteries. So they'll inject that dye and, for example, see if there's any blockages. If there are blockages, then they can put something like a stent in to help regain some of that blood flow. An electrophysiologic study is a cardiac study that's mildly invasive using a catheter that's introduced through a vein or an artery, and this helps to record the electrical activity within the heart. Next, we have a exercise electrocardiography, which is also known as a stress test. This is done to assess the heart's response to stress or exercise. For example, someone may be put on a treadmill for about 20 minutes, and they will put a pulse ox on their finger, and they will also hook them up to an EKG to see what their oxygenation status is, as well as if there are any changes in their cardiac rhythm. A transesophageal echocardiography, or a TEE, is an alternative way to perform an echocardiogram, which is a specialized probe that contains an ultrasound, and at its tip, it's passed into the patient's esophagus so they can evaluate the cardiac function. So to explain what an echocardiography is, which is also known as just an echo, this is essentially an ultrasound of the heart, and this checks how well the heart's chambers and valves are pumping blood through the heart. This measures blood flow, also known as ejection fraction. So if you look at this image up here, you'll see different labels. So here's during diastole, here's during systole. So this tells us how well that blood is being pushed out of the heart. This is going to be important to remember when we start discussing heart failure, especially left-sided heart failure. A myocardial nuclear perfusion imaging, or an MNPI. If you look at this last image on the bottom right here, the one that kind of looks like little donuts, this is a type of study that is a type of stress test that uses a PET scan. And this will give imaging of a patient's heart before and after exercise to see if there's any effect of physical stress on the heart. So this image, for example, shows that there is some ischemia occurring when there is stress on the heart. A CT scan is a non-invasive option that helps to evaluate certain factors like if there's any calcium formation in the coronary arteries, and an MRI will also help to determine if there's any changes in the cardiac wall thickness, as well as any dilation of the chambers, valve, as well as ventricular function, and even the movement of blood into the greater vessels. Now that we have the assessment information out of the way, let's go ahead and begin talking about the disorders of the cardiac system. We're going to start with hypertension, which is also known as the silent killer. And this is because it's frequently asymptomatic until it becomes severe and target organ disease has occurred. With our goal ranges of blood pressure, we have different governing bodies that give recommendations on what our blood pressure should be. The American Heart Association, for example, argues that 130/80 should be the recommended level, whereas JNC 8 has slightly different parameters. For example, people over 60 should be below 150 over 90, and that's also because of those cardiovascular changes that can occur. And then for people younger than 60, it should be below 140 over 90. There are different types of hypertension. Now, it's important to note that if you get one blood pressure reading that's, let's say, 160 over 90, that doesn't mean someone has hypertension. Usually they will need at least 2 readings by their provider before they're diagnosed with hypertension. There's also something called white coat syndrome. So some people will have elevated blood pressure only when they go to their provider's office. And this is a lot of times related to anxiety with being at the doctor's office. So again, there needs to be consistent readings before someone is actually diagnosed with hypertension. The most common type of hypertension is called essential or primary hypertension. And this can result in damage to our vital organs, such as, of course, our heart, but also other organs such as our kidneys. With this type of hypertension, there are several risk factors. We, of course, have genetics, but those who are obese, have a history of smoking, have a lot of stress. These are all factors that can lead to primary essential hypertension. Secondary hypertension, on the other hand, is caused by something else. This could be from medications, or it could be from another type of disease that is then causing elevated blood pressure. There are several risk factors for primary hypertension. There are, of course, the modifiable and non-modifiable risk factors. For example, family history, ethnicity, these, as well as gender, these are all things that we can't really control, but there are the factors that we can control. Age, of course, is one of those things that we cannot control. As we age, systolic blood pressure can rise progressively, but the diastolic blood pressure can also decrease with age. So as BP goes up, your diastolic goes down. For some of those modifiable risk factors, alcohol use, tobacco, elevated serum lipids, sedentary lifestyle, eating too much salt, stress, these are all things that can be modifiable. Although sometimes it can be very difficult to modify them, but they are still technically modifiable. Alcohol, for example. Excessive alcohol intake is strongly associated with hypertension. Moderate intake of alcohol, for example, has some protective properties for the heart. Red wine, for example. Having a glass of red wine a few times a week with dinner is considered to be healthy for the heart. Of course, you will hear both sides of the fence of that, but in general, it's thought to be helpful. If someone does have hypertension, for males, they should not consume more than 2 alcoholic beverages per day, and females should not consume more than 1 per day. Smoking tobacco greatly increases the risk of cardiovascular disease. Shocker, I know. People with hypertension who still smoke are at even higher risk of cardiovascular disease beyond just hypertension. We have vaping to consider now as well. Because vaping is still fairly new, we don't know what some of those long-term effects are going to be, but it's still thought to fall in the category of tobacco use in general. Nicotine can cause increased heart rate, which can ultimately lead to increased cardiac workload, especially over a long period of time. So I would group vaping into the same category as tobacco use. For diabetics, hypertension is more common. But when hypertension and diabetes coexist, more complications can occur, such as organ damage. There's those elevated serum lipids. With the increased cholesterol, for example, and triglycerides, this is a primary risk factor for coronary artery disease because of those fat deposits seen with atherosclerosis, which we will get a little bit more into in a little bit. Hyperlipidemia, which is high lipid levels. This is more common in people with hypertension. High sodium intake can contribute to hypertension, especially in salt-sensitive patients. It can decrease the effectiveness of certain antihypertensive drugs as well. With your individuals who have high blood pressure, they're generally going to be instructed to decrease the amount of salt that they're eating. A general rule of thumb is 1, pay attention to food labels, and 2, don't add any salt to your food. Gender can also be a factor. So hypertension is actually more common in men in young adulthood and early middle age, but after the age of around 64, 65, high blood pressure is actually more common with women. You may wonder where socioeconomic status comes into play, and that can be a variety of things. That could be from more sedentary lifestyle because maybe they are working too much, which can also then lead to stress. But you also have to think about with lower socioeconomic status, they may select poor food choices because they are cheaper. For example, $1 can get you something at McDonald's versus something that is a well-balanced meal. So there is a lot to consider when someone has a lower socioeconomic status. So it's really important to consider what kind of food alternatives these individuals can have that can help control their high blood pressure. Hypertensive crisis or malignant hypertension is something that we worry about with any patient who has high blood pressure. This is a medical emergency. This is when the systolic blood pressure is over 200 or even if the diastolic pressure is over 150. This can put your patient at high risk for cardiovascular events such as a stroke. And symptoms can include a morning headache, as well as changes in vision, shortness of breath, or even uremia. Here are some additional risk factors for essential hypertension. First is African American ethnicity. It's one of those family genetic risk factors. Hyperlipidemia, history of smoking, someone who's over 60, as well as those who are physically inactive or sedentary lifestyle and are obese. With secondary hypertension, the biggest risk factor is going to be kidney disease. The assessment procedures are going to be the same as what I've already talked about in previous slides. So if you go through those, that will also encompass your assessment for high blood pressure. In terms of diagnostics, although there are no lab tests or diagnostics specific for essential hypertension, several labs can be done to assess possible causes of secondary hypertension. Kidney disease, for example. This can be diagnosed by the presence of proteins as well as red blood cells in urine, as well as elevated levels of BUN and creatinine. GFR is another one that can be looked at, and this tells us how well those kidneys are filtering out. So a normal value is somewhere between 90 to 120. So the lower someone is, if they're below 90, this could be indicative of reduced kidney function, which can then lead to secondary hypertension. Our overall goals are going to, of course, be to control blood pressure, whether that's through moving around more, controlling salt intake, taking meds consistently. The more we control that blood pressure, the more we reduce the cardiovascular disease risk factors. Lifestyle modifications may include dietary changes, weight reduction. 22 pounds can actually decrease the systolic blood pressure by about anywhere between 5 to 20, which can be pretty significant for some individuals. The recommended diet for someone with hypertension is to follow the DASH diet, and this is considered to be a heart-healthy diet that is lower in sodium. We generally encourage a decrease in the amount of sodium one consumes, so usually it's going to be less than 2,000 milligrams per day in healthy adults, but those who have hypertension, we usually want them to consume much less than that. With alcohol intake, we usually don't tell our patients, you have to stop drinking alcohol. If they otherwise have normal liver function, we just tell them continue to drink if you would like to, but do so in moderation. With tobacco products, on the other hand, though, because it causes vasoconstriction, it causes the blood pressure to go up. So we actually want patients to stop smoking tobacco altogether. Increasing physical activity is going to be important, of course, with blood pressure control, but overall health, it can release endorphins, it can help with weight management, helps with circulation. So there's a lot of benefits with physical activity. If you have someone who's a little resistant to physical activity, you can even give them a goal of starting out with 30 minutes of walking 3 times a week. So you have to start small sometimes and then work your way up to the recommended amount of physical activity. You also need to identify any potential for decreased adherence to the treatment plan. So is your patient actually going to stop smoking? Are they going to start exercising more? So you need to continue to reinforce, help to encourage, stay positive for your patients, but also evaluate if they are not sticking to the treatment plan or even not taking their medications consistently. You need to identify what are factors that are causing them to not participate or that are affecting their ability to fully participate in that treatment plan. With the evaluation of our outcomes, we would prefer that our patients are able to verbalize an understanding of the plan of care and, of course, be in agreement. You can't just sit there and bark orders at your patient. You have to find some sort of common ground. So again, someone who lives a sedentary lifestyle, sometimes it comes down to finding something that they enjoy doing that's physically active that will help to motivate and encourage them. Also, medication management. If they are given medications, you have to reinforce, you have to consistently take these medications every day in order for them to do their job. If they start experiencing side effects, they should communicate these side effects. So if there's an alternate drug out there, then that could be considered. Now let's talk about arteriosclerosis and atherosclerosis. Arteriosclerosis is a thickening or hardening of the arterial wall. And this can actually happen as we age naturally. With atherosclerosis, this is basically fatty mush, so fatty deposits that develop within the arteries. With both of these, it can lead to other complications like high blood pressure, peripheral vascular disease, peripheral artery disease, MI, etc. So with atherosclerosis, if you look at this image on the right, you have a normal, free-flowing artery with good blood flow. Over time, say someone who is sedentary, who has high lipids, this puts them at risk for this. So they start getting these fatty deposits, which are going to start obstructing blood flow that can lead to high blood pressure, again, MI, PVD, PAD. The more fatty deposits there are, that also puts them at risk for those little red blood cells starting to build up clots, and then also puts them at higher risk for stroke. With your assessment of both of these, it's really going to be the same as the previous assessment information that I've already discussed, but you also need to identify what are their lifestyle habits. Can we do some participation in changing up those modifiable risk factors, such as their nutrition and activity? Peripheral arterial disease, or PAD, is a form of peripheral vascular disease. This leads to blockages from atherosclerosis in those arteries. So if you look at this image on the right here, these are some of the common areas that you may have those fatty deposits, which then leads to more systemic atherosclerosis and those symptoms of PAD or PVD. As we age, the risk for PAD will increase, and usually we will become symptomatic around 60s, 70s, or 80s. And in people with chronic conditions like diabetes, PAD can occur much, much earlier because of the havoc that diabetes wreaks on the body. This is a largely underdiagnosed condition because, again, a lot of people are completely asymptomatic. They have no idea that they have it. Some of the major risk factors include tobacco use, chronic kidney disease, diabetes, high blood pressure, and hypercholesterolemia or hyperlipidemia. Some other risk factors can include chronically elevated CRP, family history, increasing age, as well as obesity, sedentary lifestyle, and chronic stress. Intermittent claudication is a classic symptom of PAD. This is an ischemic pain that's a result of the buildup of lactic acid from exercise or moving around. Once the patient stops exercising or, for example, walking, the lactic acid will clear up and then the pain will subside. So in other words, it goes away with rest. PAD of the iliac arteries will produce claudication in the buttocks or the thighs, whereas calf claudication will be more indicative of femoral or popliteal artery involvement. So depending on where that blockage is, that will determine where those symptoms or that claudication is going to occur. While many patients report those classic symptoms of claudication of PAD, there are many patients out there who really have no symptoms and have no idea that they have it. But there are also those patients who will have more atypical leg symptoms like a burning or heaviness, pressure, muscles feeling sore even though they haven't worked out, generalized tightness. And it can also be in atypical locations, maybe the ankle, foot, more the hamstring. Now, older women will also experience the classic claudication less often than men. Paresthesia will result from nerve tissue ischemia, but true peripheral neuropathy will occur more often with patients who have diabetes, as well as those with long-standing ischemia. This can lead to more of a shooting or burning pain in the extremities, especially the lower extremities. Some other signs and symptoms to look out for are changes in the skin. So people who have PAD or PVD will have more thin, kind of shiny appearing skin that could even appear a little dry or tight. The skin also tends to appear more mottled, so it's kind of blotchy and a darker brown color, or it can even be a red color. You may also see that there's a loss of hair on the lower legs, especially around the ankle area. Now, this is one of those situations where you have to look at all of the signs and symptoms. Sometimes we have male patients who don't have things like PAD or PVD, and they have loss of hair on the lower legs near the sock line. And this is just from over years pulling socks up over the legs. It's not that they have PVD or PAD. So if all they have is hair loss, this could be from that. But if their skin looks kind of mottled, thin and shiny, then that could be indicative of PVD. It's really important to assess the pedal pulses. If you see that there's a variation in the pedal pulses, then that could indicate that there is atherosclerosis occurring in one of those arteries. Pallor of the foot with leg elevation, so the foot turns kind of a pale color when it's elevated. Dependent rubor refers to a dependent position that will lead to redness. So, for example, if I'm sitting in a chair, my lower extremity may turn a red color, and it can even cause some swelling. So here's a good example for you. You have some of that kind of mottled appearance that I was talking about, so it's kind of brown in color. Here in the middle, we have swelling. So obviously the left leg is the one that's affected in this image, and you also have those skin color changes. In this image on the far right here, you have that ulcer. So with chronic PVD or PAD, it can lead to these non-healing wounds because of that poor perfusion. General complications include atrophy of the skin as well as underlying muscles, delayed wound healing. Your arterial or ischemic ulcers most often occur over bony prominences on the toes, feet, and lower legs. But I feel like they especially occur around the ankles, like in that previous image that I showed you. There are several diagnostics that can be done. Your MRA or magnetic resonance angiography, this is commonly used to assess the blood flow in the peripheral arteries. A Doppler can also be used, and this helps to identify what the segmental systolic blood pressure measurements are of the lower extremities, especially at the thigh, calf, and ankle. Ankle brachial index, or ABI, this is used to evaluate the outflow of disease, so we compare ankle pressure with brachial pressure. Exercise tolerance can also be performed, so this can either be with the administration of drugs or doing something similar to a stress test where they walk on a treadmill, and this is to determine if they start to experience that claudication, so that pain of the muscles. Interprofessional care is going to be pretty similar to hypertension. So smoking cessation, blood pressure management, we want to have our patients exercise. This helps to promote perfusion as well as maintaining the muscle mass. So for example, we want them walking 30 to 45 minutes daily. If not daily, then at least 3 times a week. Positioning can be a little more controversial with your patients who have PVD. If they're elevating it because they have that dependent rubor, they can, but they should not go above heart level. Vasodilation is also really important. We want them to avoid cold, tobacco, caffeine, stress, because all of these can cause vasoconstriction. We instead want them to apply warmth to help with vasodilation. Drugs generally will include blood thinners so that they don't have any clot formation. So we worry about things like DVT or worse. Peripheral venous disease really just refers to thrombus formation. So venous thromboembolism, or VTE, encompasses DVT as well as pulmonary embolism. This can be from a variety of causes, like defective heart valves, because this can lead to venous insufficiency as well as varicose veins, which are not life-threatening but can be problematic. Skeletal muscles that don't contract to help pump blood in the veins. This problem can occur more when weight bearing is limited or muscle tone will decrease. Virchow's triad is dependent on 3 factors, and these include stasis, vessel damage, and hypercoagulability. In general, you need to assess for risk factors, so any history of venous thromboembolism, any history of hypertension, valve disorders, do they have any history of PAD, anything that can affect blood flow as well as clotting, abnormal clotting of the blood. Patients may be completely asymptomatic, so again, you need to do a thorough assessment. For example, if you have a patient who has had surgery, we of course know that we're going to assess for things like DVT by checking the calf. Sudden onset or unilateral leg swelling with warmth and discomfort, that would be a strong indicator of something like a DVT as well as unequal pulses. If we're thinking more pulmonary embolism, we get more into that in n196, but that would be a clot that goes into the pulmonary arteries. PVD will generally include anticoagulation, such as medications, but there are some patients who may need an IVC filter so that we don't cause the blood clot to move and travel up and cause a pulmonary embolism. We will probably anticipate that we're going to give medications such as anticoagulants. This could be Coumadin, heparin, Lovenox, etc. But some patients may also need an IVC filter so that they don't have for example, a DVT, so that it doesn't dislodge and then turn into a pulmonary embolism. Some patients may need revascularization surgery. This can be if there's extensive damage or in general if someone has peripheral artery disease. Some of our interventions other than administering medications are to, of course, assess. We're assessing for DVT or for pulmonary embolism, keeping those legs elevated, checking those calves, checking pedal pulses, labs, for example, platelets and PT-INR. We can also apply heat because, again, we're trying to vasodilate. And lastly, activity. The more they move around, the lower their risk is going to be of developing something like a VTE.